Hello everybody. Today we are going to discuss a very important topic. Whenever I say ABG, arterial blood gas analysis, this will be expression of many because it is mathematics. So we'll wait up to 9:20 and we'll start. I hope everything is audible and visible, students. Whenever I say ABG, arterial blood gas analysis, this will be expression of majority because it is mathematics. So we all hate mathematics. That's why we have coming to MBBS. Just like one's girlfriend, now mathematics is back with vengeance. So arterial blood gas analysis, I want everybody to join. 1 minute. Okay. So we are going to do ABG under two headings. So basic ABG course, so it will be done today. This extra edge, which usually is not required for routine clinical practice. If they give any theory questions, you may need to answer buffering mechanisms, ABG sampling technique, mechanisms of renal disorders, all those. So this will be recorded. So this is about a 3-hour video, and this will be about 2.5 hours because we cannot complete the 5 hours. So this is more of practical approach, what I am going to discuss today. The theoretical part, it will be recorded and it will be uploaded in the same app. Coming to the fundamental definitions, whenever I say acid-base balance, the fundamental definitions that you should know: what is pH, what is acid, what is base. Have you ever imagined what is meant by pH? pH is nothing but power of H plus. How much H plus is present in a patient's body. This pH, the mathematical formula. To understand ABG, you should know simple mathematics and chemistry. Mathematics in the sense as simple as addition, subtraction, multiplication, and simple chemistry. What is pH, what is acid, what is base. pH is negative logarithm of H plus ion concentration. Whenever I write anything negative, I can also write it as, in logarithmic terms, pH is equal to log of 1 by H plus. Can anybody tell me, with this relation, what will be the association between pH and H plus? Mathematically, when you find an equation like this, pH should be inversely proportional to H plus. This is the first important relationship. This is the first important relationship that everybody should know. pH is proportional to 1 by H plus, or pH is inversely proportional to H plus. That means if H plus is increasing, automatically pH will decrease. Possibility 1. If in a patient body H plus increases, automatically pH will decrease. Anywhere decrease in pH in chemistry is called as acidosis. Then possibility 2. Whenever H plus decreases, automatically pH will increase because they are inversely related. Possibility 2. H plus decreases, pH will increase. It means alkalosis. For all practical purposes, acidosis and alkalosis, we generally mention in terms of pH only, not H plus, because the absolute value of H plus is in multiple decimals. It is practically not easy to represent. In simple words, decrease in pH is acidosis, increase in pH is alkalosis. Next question, what is meant by acid? In chemistry, acid is a substance which can donate or release H plus, which can give H plus. A molecule that is capable of giving H plus, it is called as acid. One of the strongest acid is HCl. Why HCl is an acid? Because it is releasing H plus. Why HCl is an acid? Because it is releasing H plus. In the same way, in your body, abundant acid is not HCl. It is H2CO3, carbonic acid. Can anybody tell me from where carbonic acid is produced from? Carbonic acid is produced from carbon dioxide. This is a very important equation. If you see in this equation, CO2 plus H2O, it is giving rise to carbonic acid, and carbonic acid is the one giving H plus. In simple words, CO2 is the source of H plus in your body. So it should be considered as acid. CO2 is the one ultimately giving rise to H plus in the body. That's why CO2 is considered as acid in your body. For example, in a patient's body, if CO2 increases excessively, if CO2 increases, automatically more H plus will be produced in the body. Whenever H plus increases, what will happen to pH, students? pH will reduce. Anywhere decrease in pH should be called as acidosis. It is due to CO2. That's why it is called as respiratory acidosis. In very simple words, carbon dioxide retention is nothing but respiratory acidosis. On the other hand, because of some disease, if CO2 is decreasing, there is less CO2 in your body. If there is less CO2, the chances of H plus formation will be less. So what will happen to H plus? H plus will be reduced. Whenever H plus reduces, pH can increase. Anywhere increase in pH is alkalosis, and this is due to CO2. That's why it is called as respiratory alkalosis. Again, very simple words, CO2 washout is nothing but respiratory alkalosis. My simple question to you students, can anybody tell me what is the relationship between CO2 and pH? Can anybody tell me what is the relationship between CO2 and pH? Here CO2 has increased, pH is decreasing. CO2 is decreased, pH has increased. So it is an inverse relation because the change is in opposite direction. pH is proportional to 1 by CO2. This is next important relationship in ABG. Then coming to what is meant by base. You must be knowing acid and base are mutually opposite phenomena. Acid is something which gives H plus. What is opposite of giving? It is taking. Base is something which eats H plus. takes up H plus, accepts H plus. Molecule that can accept H plus, it is called as base. Why is sodium hydroxide, NaOH, considered as a strong base? Because here OH minus ion can eat up H plus, because it is going to take up H plus. It is considered as a strong base. But in your body, most abundant base eating H plus is not OH minus, it is bicarbonate. Bicarbonate actively accepts H plus. That's why in your body bicarbonate is the base. Bicarbonate is the base. Because of some disease, if bicarbonate increases, what will happen in this patient's body? Because there is a lot of bicarbonate, it will eat up all the free H plus. So the free H plus in your body will reduce. Whenever free H plus is reducing, that will result in increase in pH. pH will automatically increase. Wherever pH increases, it is called as alkalosis. And this is due to bicarbonate. That's why it is called as metabolic alkalosis. Metabolic alkalosis. Then, because of some disease, if bicarbonate is decreasing, there is nothing accepting H plus. So what will happen to H plus? It will increase. So there is nothing eating H plus. If H plus increases, pH tends to decrease. Anywhere decrease in pH, it is called as acidosis, and it is due to bicarbonate. That's why it was called as metabolic acidosis. In very simple words, bicarbonate retention is metabolic alkalosis. Bicarbonate loss is metabolic acidosis. Bicarbonate loss is metabolic acidosis. Then, can anybody tell me the relationship between bicarbonate and pH? Here bicarbonate is increasing, pH is also increasing. Bicarbonate is decreasing, pH is also decreasing. So in same direction, it should be a direct relation. pH is directly related to bicarbonate. We have two relations here. Now I am going to merge these two. Can I write in this manner? pH is directly proportional to bicarbonate, inversely proportional to CO2. This is the most basic relationship in ABG. pH is directly proportional to bicarbonate, inversely proportional to CO2. But this is not a proper mathematical equation. When do you call it as proper mathematical equation? When you have equal to symbol. But here there is proportionality symbol. Now I am going to remove this proportionality symbol, insert equal to symbol by adding some constant values. That standard equation which tells you the relationship between pH, bicarbonate and CO2, it is called as Henderson-Hasselbalch equation. It is called as Henderson-Hasselbalch equation. Write down, students. This is the most important mathematical equation for acid-base balance. We have understood up to now pH is proportional to bicarbonate by CO2, making a mathematical equation pH is equal to 6.1 plus log of bicarbonate by PaCO2 log of bicarbonate by PaCO2 into 0.03. Just like in mathematics, we have a plus b whole square is equal to a square plus b square plus 2ab. This is such basic equation. Let us see what are the normal values. As I told you, for ABG analysis, these three values are very important. Let us see their normal range. pH, the normal range is 7.35 to 7.45. PaCO2, the normal range is 35 to 40 mmHg. Bicarbonate, the normal value is 22 to 26 milliequivalent. And another important value that you should see in ABG is oxygen, P small a(O2). It is generally 80 to 100 mmHg. But important to assess the acid-base disorder will be these three values: pH, PaCO2 and bicarbonate. pH, PaCO2 and bicarbonate. In this present lecture, any pH less than 7.35, any pH less than 7.35, it is called as acidosis. Acidosis. pH more than 7.45, it is called as alkalosis. In simple words, if pH is less, acidosis. If pH is more, alkalosis. Then in this present lecture, for calculation convenience, let us take normal CO2 as 40, bicarbonate as 26. We are taking the upper limit, 40, 26. Now I'll give you few examples. Tell me what is the disorder. I am sitting in this room and I have suddenly stopped respiration. What will be the acid-base disorder, students? Whenever I stop my respiration, what is going to happen? In my body, CO2 will increase. Whenever CO2 increases, automatically what should happen to pH? pH should decrease. Anyway, decrease in pH is acidosis. This is due to CO2. So we call it as respiratory acidosis. In the same way, now I am running for 2 kilometers and I am hyperventilating like this. Whenever I hyperventilate, what is the gas going out in excess? CO2. So CO2 will reduce. Whenever CO2 reduces, automatically pH will increase. Anywhere increase in pH is alkalosis. This is due to CO2. This is called as respiratory alkalosis. Very simple. Another example, there is a patient with diabetic ketoacidosis. Because of accumulation of keto acids, his bicarbonate decreased. If bicarbonate decrease, pH will automatically decrease. This decrease in pH is acidosis. This is due to bicarbonate. It is called as metabolic acidosis. Whenever there is a patient with DKA, metabolic acidosis, what will be the special pattern of breathing in him, students? What will be the special pattern of breathing? It is called as Kusumal's breathing. Kusumal's breathing is very, very rapid breathing. Now, why will this patient generate such a rapid breathing? What is the reason behind this? Very simple. Already there is metabolic acidosis in your body. To fight against this metabolic acidosis, your respiratory system will try to send acid-like substance called as CO2 out. By doing that very, very rapid breathing, there is CO2 washout. For metabolic acidosis, your body is trying to compensate with respiratory alkalosis. See, in your body, whenever there is any abnormality, your body will try to fight against this. In the same way, this acid-base balance is also like action-reaction. In your body, if action is acidosis, your body will fight or react by generating alkalosis. If action is alkalosis, reaction given will be acidosis. If action is by metabolic system, reaction will be through respiratory, and it will be vice versa. So this primary event is called as primary disorder, and the reaction given by your body is called as compensation. Now, why there should be reaction by your body or compensatory phenomena by your body? It is just a defense mechanism, students. For example, if patient is developing acidosis or alkalosis, so the pH, if there is no compensatory phenomena, the pH will progress to an extreme value where your body's metabolism will not happen. Now these compensatory phenomena will try to bring the pH to near normal so that it will give time to the patient's body to fight against the disease further, or it will give time to the patient to get the disease treated. So these compensatory phenomena are nothing but temporary phenomena which will try to bring the pH to near normal. In very simple words, if primary issue is increase in CO2, it is called as respiratory acidosis. How will your body fight? By increasing bicarbonate, metabolic alkalosis. In the same way, if primary issue is increase in bicarbonate, metabolic alkalosis, how your body will fight? By increasing CO2, respiratory acidosis, and it will be vice versa. This acid-base balance follows the principle of action-reaction. For acidosis, there will be alkalosis. If action is through respiratory, reaction will be through metabolic, and it is vice versa. Write down what is meant by compensatory response. This is a response that will try to return the pH to near normal. Body attempts to return the pH to near normal through compensatory process. For example, if primary process is the villain, your body will fight against it with a compensatory response. This is a fight always going on your body in acid-base balance. For a primary process, your body will try to fight with a compensatory response. Presence of a primary process with adequate compensatory response, it is called as simple acid-base disorder. When there is a primary process and also there is adequate compensatory response, it is called as a simple acid-base disorder. Write down what is meant by simple acid-base disorder. There will be a primary process. To that, your body will give adequate compensatory response. Adequate compensatory response. First of all, Let us try to understand how to identify the primary process. Write down all the primary process that can be possible. Respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. Let it be any of this. We will see the trend of pH, PaCO2, bicarbonate. pH, PaCO2, bicarbonate. Let us start with respiratory acidosis. Very simple. I am not going to teach anything new. Whatever we have discussed up to now, let us apply it here. To call it as acidosis, students, to call it as acidosis, what should happen to pH? pH should reduce. To call it as a primary respiratory event, where the change should be CO2. What should happen to CO2? CO2 should increase. Increase in CO2 is respiratory acidosis. For respiratory acidosis, what is compensation? I told you, for respiratory metabolic, for acidosis, alkalosis. Bicarbonate tends to increase. How this compensatory phenomena happens, in the next lecture, in the recorded version, I have explained it in detail. Just go through. Then, to call it as alkalosis, pH will increase. To call it as a primary respiratory phenomena, where the change should be CO2. What happens in respiratory alkalosis? CO2 washout. For respiratory alkalosis, compensation, metabolic acidosis. In the same way, to call it as acidosis, pH should decrease. To call it as a primary metabolic disorder, what should happen to bicarbonate? Bicarbonate should decrease. For metabolic acidosis, what is compensation? Respiratory alkalosis, CO2 will decrease. Best example, diabetic ketoacidosis is metabolic acidosis. Compensation, Kusumal's breathing is nothing but respiratory alkalosis. To call it as alkalosis, pH will increase. To call it as a primary metabolic phenomena, where the change should happen? Bicarbonate. So what should happen to bicarbonate? It should increase. For metabolic alkalosis, what is compensation? Respiratory acidosis. This is how simple acid-base disorders behave. To understand this better, there are three important rules. Rule number 1. In a simple acid-base disorder, always primary change, and compensation, will move together. What does this mean? Let it be any disorder. If you observe primary change, compensation, primary change and compensation. They are moving together. It means if primary change is increase in CO2, compensation increase in bicarbonate. If primary change is increase in bicarbonate, compensation will be increase in CO2. And it is vice versa. This is rule number 1. Coming to rule number 2. In primary respiratory disorder, change in pH WRT with respect to CO2 and bicarbonate in opposite direction. If it is a primary metabolic disorder, change in pH with respect to CO2 and bicarbonate in same direction. So what does it mean? In a primary respiratory disorder, change in pH with respect to parameters, it is in opposite direction. In a primary metabolic disorder, change in pH with respect to parameters, it is in same direction. Now what is the logic behind this? Very simple concept. To call it as a primary respiratory disorder, change in pH is predominantly happening to CO2, due to CO2. How is pH and CO2 related? Inverse. So if CO2 increases, pH will decrease. If CO2 decreases, pH will increase. Here the logic is, in primary respiratory disorder, change in pH is predominantly due to CO2. pH and CO2 have inverse relation. So change in pH with respect to parameters will be in opposite direction, as pH will follow CO2 here. Rule number 3. To call it as primary metabolic disorder, change in pH is due to bicarbonate. How is pH and bicarbonate related? It is direct relation. It means if bicarbonate increases, pH increases. If bicarbonate decreases, pH also decreases. The logic here is, to call it as a primary metabolic disorder, change in pH is due to bicarbonate. Both are directly related. So change in pH with respect to parameters should be in same direction. Even if you forget this logic, don't forget this mnemonic called as ROME, ROM. What does it mean? In a primary respiratory disorder, the change will be in opposite direction. You can see change in pH with respect to parameters, opposite direction. In a primary metabolic disorder, the change will be in same direction. If you do some questions, you will understand this better. Whenever they give you any ABG, if you see in the emergency department or in the ICU, if you are not used to ABG analysis, first write down the parameters on a white paper like this. And what you need to do is just see the trend of values. Draw arrow marks. pH reduced, CO2 increased, bicarbonate increased when compared to normal values. Anywhere decrease in pH should be called as acidosis. This everybody will identify because pH has decreased. Now what is the primary disorder? Is it respiratory or metabolic? See here, pH has decreased but other parameters have increased. Change in pH with respect to parameters, it is in opposite direction. So what should be the primary? It should be respiratory. Very simple. For practice, this is question number 1. Question number 2, you can start answering. What are these disorders? Question number 3, question number 4. Just draw arrow marks, you will get the answer. pH increased, CO2 decrease, bicarbonate decrease. Anywhere increase in pH is called as alkalosis. Alkalosis. Change in pH with respect to parameters, it is in opposite direction. It is in opposite direction. So what should be the primary? Respiratory. So this is a respiratory alkalosis. This is a respiratory alkalosis. Then third, pH reduced, CO2 reduced, bicarbonate reduced. Here pH is reduced, no doubt it is acidosis. Change in pH with respect to parameters, it is in same direction. So what should be the name? Metabolic. Then fourth, pH increased, CO2 increased, bicarbonate increased. Increase in pH is alkalosis, that we all know. Then change in pH with respect to parameters, it is in same direction. What should be the name? Metabolic. Once again, going through all those 3 rules. Let it be any disorder, always primary compensation. Primary compensation will be moving together. If it is a primary respiratory disorder, change in pH with respect to parameters, opposite direction. In a metabolic disorder, change in pH with respect to parameters in same direction. What was the definition of simple acid-base disorder? There is a primary process, to that your body will give adequate compensatory response. Let us calculate that compensatory response. For each and every disorder, there is a standard formula. You know, if there is primary respiratory disorder, you should calculate metabolic compensation. If there is a primary metabolic disorder, one should calculate respiratory compensation. It is all formula based. These are standard formulas. Let us see the standard formula for respiratory acidosis, acute, chronic. Respiratory alkalosis, acute, chronic. Now in acute respiratory acidosis, for every 10 mm Hg increase in CO2, for every 10 mm Hg increase in CO2, This is an acute phenomena. Still your kidneys are not used to this. Bicarbonate increases by how much? 1 milli equivalent. Chronic, for every 10 mm Hg increase in CO2. This is a chronic disorder. Your body has adjusted. Bicarbonate increases by 4 milli equivalents. How to exactly tell whether it is acute or chronic? Patient's clinical history is very important. Sudden history, acute. Gradual history, chronic. Say for example, foreign body aspiration. It comes under acute. Ongoing neuromuscular disorder, chronic. How to calculate compensation? Now, due to an acute disorder, if CO2 has increased from normal value of 40 to 60, to call it as a compensatory phenomena, bicarbonate should increase to how much? For 10 it is 1, for 20 it is 2, 26 plus 2, if CO2 comes to 28, it is compensated. Then chronic respiratory acidosis. In a chronic disorder, if CO2 increases from 40 to 60, to call it as a compensatory phenomena, what should happen? For 10 it is 4, for 20 it is 8, 26 plus 8, 34. If your body has made bicarbonate to 34 from 26, it means it has given an adequate compensatory response. For respiratory alkalosis, the formulas are slightly different. For every 10 mm Hg decrease in CO2, bicarbonate decreases by 2 milli equivalent, slightly different formula. For every 10 mm Hg decrease in CO2, bicarbonate will decrease by 4 milli equivalents. Bicarbonate will decrease by 4 milli equivalents. Bicarbonate decreases by 4 milli equivalents. Now let us do a question so that we can understand better. There is a patient with chronic neuromuscular disorder. His pH was found to be 7.32, PaCO2 60, bicarbonate 34. Quickly tell me what is the primary disorder and also calculate compensation. Draw arrow marks. pH reduced, PaCO2 increased, bicarbonate increased. Anywhere decrease in pH is acidosis. Change in pH with respect to parameters, it is in opposite direction. So it is a primary respiratory acidosis. Is it acute or chronic? It is chronic. Now how to calculate compensation? In this question, CO2 has increased from normal value of 40 to 60. It means it has increased by 20. To call it as a compensatory phenomena, bicarbonate increases from 26 to how much? For 10 it is 4, for 20 it is 8, 26 plus 8, 34. Given in the question and expected value is correlating. So it is adequate compensation. Chronic respiratory acidosis with compensatory metabolic alkalosis. but I am very lazy to write this big name. What I can write? Is it acute or chronic? Chronic. Is it compensated? Yes. Adequately compensated? Yes. Whenever you want to write one process, you should always mention the primary disorder. The complete name is chronic respiratory acidosis with compensatory metabolic alkalosis, or in simple words, chronic compensated respiratory acidosis. This is how you should calculate compensation for a primary respiratory disorder. Then calculation of compensation for metabolic disorder. Metabolic acidosis, metabolic alkalosis. Write down compensation for metabolic acidosis, metabolic alkalosis. For metabolic acidosis, there is a very special formula called as Winter's formula. What does this mean? Expected CO2 is equal to 1.5 into bicarbonate plus 8 plus or minus 2. If you do some questions, you can understand better. pH 7.29, PaCO2 22, bicarbonate 10. Quickly tell me the acid base disorder here, students. pH reduced, CO2 reduced, bicarbonate reduced. Anyway, decrease in pH is acidosis. Change in pH with respect to parameters, it is in same direction. So what should be the name? Metabolic. For primary metabolic acidosis, you should calculate respiratory compensation. So how to calculate? Expected CO2 is equal to 1.5 into bicarbonate 10 plus 8 plus or minus 2, 15 plus 8 plus or minus 2, that is 23 plus or minus 2. It will be in the range of 21 to 25 mmHg. Given is how much? 22. Expected correlating. So this is a metabolic acidosis with compensatory respiratory alkalosis. This is how you should interpret. Then for metabolic alkalosis, there is a simple formula. Expected CO2 is equal to bicarbonate plus 15. Very simple formula. In a scenario, if you identify primary metabolic acidosis, you should calculate compensation with this formula. If you identify a primary metabolic alkalosis, you should calculate compensation with this formula. Whatever we have learned up to now, let us put it into an ABG algorithm. Before ABG interpretation, most important initial step is patient's clinical history. Before seeing the numbers, you should go through patient's clinical history. What is the reason behind this? Very simple. Ultimately, you are not going to treat those numbers. You are going to treat the disorder responsible for the numbers. Now, diabetic ketoacidosis, renal failure, diarrhea, all this can cause the same metabolic acidosis. But based on clinical history, the treatment for diarrhea, diabetic ketoacidosis, renal failure, all are completely different. That's why clinical history is very, very important in ABG. Before looking at the numbers, look at patient's clinical history. Then, first step, by seeing the pH, you should be able to tell, are you dealing with acidosis or alkalosis? Acidosis or alkalosis. Then, second step, what is the primary disorder? Is it a primary respiratory disorder? Disorder in the sense it can be acidosis or alkalosis, or metabolic disorder. After primary disorder, next is compensation. If it is a primary respiratory disorder, what compensation you should calculate? Metabolic compensation. If it is a primary metabolic disorder, you should calculate respiratory compensation. By given set of formulas, you have to calculate. In majority of the situation, given bicarbonate can be correlating with expected bicarbonate. On this side also, given CO2 will be correlating with expected CO2. If given and expected are correlating, it is adequate compensation. You can just write it as simple acid-base disorder. Simple acid-base disorder. If given and expected are not correlating, this can happen uncommonly. Given bicarbonate is not correlating with expected bicarbonate. On this side also, given CO2 is not correlating with expected CO2. When given and expected are correlating, it is simple, adequate compensation. When they are not correlating, it is inappropriate compensation. Whenever clinical history is not known, previously we were using the terms decompensation, partial compensation, or overcompensation. But according to new edition of Harrison, when there is a clinical scenario, all these terms are not used. Now we use a single term called as mixed acid-base disorder. So in very easy words, if it is correlating, it is simple. If it is not correlating, given and expected, it is mixed. Don't worry about mixed acid disorders as of now. When I discuss all the individual acid-base disorders, simple ones, then we will go into mixed. After this, next step will be fourth step, calculation of anion gap. Anion gap in blood. Very important step. And if at all there is high anion gap, one should compare change in anion gap, written as delta anion gap and change in bicarbonate written as delta bicarbonate. What is this anion gap is our next topic of discussion. And the last step, putting all these parameters and clinical history together and giving your final impression. This is the simplest ABG algorithm. Just 5 steps. See the pH, acidosis or alkalosis. What is the primary disorder? Compensation, anion gap, final impression. Let us see what is this anion gap and also metabolic acidosis. Write down concept of anion gap and metabolic acidosis. For this you need some imagination. In my body there are 2 compartments. A positive compartment, a negative compartment. To maintain electron neutrality, always the total number of positives will be equal to total number of negatives. But routinely bedside, what are the positives we measure? Na plus, K plus. Routinely bedside, what are the negatives we measure? Chloride, bicarbonate. In a normal individual, always between measured positives and measured negatives, there is a significant difference. That difference is called as anion gap, Ag. Write down. Anion gap is considered as the difference between measured positives and measured negatives. Anion gap is considered as the difference between measured positives and measured negatives. Let us take for example negative compartment. This is the measured part and this becomes the unmeasured part. Let me get something to show you this in an easy manner. Say for example, this is negative compartment. Whatever you see up to here is measured part. This is unmeasured part. Now because of some disease, if measured part is decreasing, automatically unmeasured part will increase. In the same way, because of some disease, if unmeasured part is increasing, automatically measured part will decrease. Just like in this bottle, always the measured part and unmeasured part will adjust to maintain total volume of the given compartment. Now what is present in measured positive? Sodium. How much is the value of sodium? 135 to 145. Potassium, it is only 3.5 to 4.5. When compared to sodium value, potassium value is very less. So recently, for calculation of anion gap, we stopped taking potassium. New formula for anion gap is equal to sodium minus chloride plus bicarbonate. If you calculate with this formula, normal anion gap will be 8 to 12 milli equivalents, or 10 plus or minus 2 milli equivalents. The reference value is generally taken as 10. The reference value is generally taken as 10. So this is something routinely happening in all of our bodies. In all of our bodies, in between measured positives and measured negatives, there is a significant gap. This gap is called as anion gap. This gap is called as anion gap. Let us see how will this anion gap influence metabolic acidosis. The first type of metabolic acidosis is a high anion gap metabolic acidosis. Once again, the same compartments, a positive and negative. What is positive? Predominantly made up of sodium. What is negative? Made up of chloride and bicarbonate. Always between these two there is a significant gap called as anion gap. Say for example, this is a normal individual's body. For development of high anion gap metabolic acidosis, the primary event is addition of acid to body. You must be knowing any acid in the universe will give rise to H plus and corresponding acid anion. Say for example, if the acid is H2SO4, it gives rise to H plus HSO4 minus, HNO3, H plus NO3 minus. The same way, lactic acid, H plus lactate, acetic acid, H plus acetate. Let it be any acid, it finally gives rise to H plus and acid anion. Whenever H plus is increasing in your body, what is the most important buffer for H plus? Bicarbonate. So to fight against this excess H plus, this bicarbonate is consumed as buffer. Because bicarbonate is getting consumed, this phenomena is called as metabolic acidosis. So the value of bicarbonate is decreasing. Simultaneously, what will happen is this acid anion is negatively charged. It starts accumulating in the unmeasured compartment. It starts accumulating in the unmeasured compartment. Because of these two events, your anion gap becomes persistently high. Previously, anion gap was only this much. Now it has increased to this much. There is metabolic acidosis and it is associated with high anion gap. So it is called as high anion gap metabolic acidosis. What you have to keep in your mind here is, after addition of acid, 3 steps. Bicarbonate consumed as buffer, acid anion being added, both resulting in persistence of high anion gap. Write down the mechanism, you will understand better. Mechanism. The mechanism is rise in anion gap. Rise in anion gap is due to simultaneous decrease in bicarbonate and increase in unmeasured anion. What is this unmeasured anion? It is nothing but acid anion. This is the basic mechanism. To understand this better, I have made a simple video. Can anybody tell me what is this? This is a positive compartment, negative compartment, and this is the anion gap. So initially, for representation, this much is the anion gap. To this body, I am adding acid. To this body, I am adding acid. After addition of acid, observe these three events. After addition of acid, bicarbonate getting consumed as buffer, acid anion being added, both put together causing increase in anion gap. Previously only this much was the gap, now it has increased. See once again, bicarbonate consumed as buffer, acid anion added, both put together increasing the anion gap. If you see in the ABG, you can only notice rise in anion gap and decrease in bicarbonate. You don't see this unmeasured anion. That's why there is a relation. For every 1 milli equivalent increase in anion gap, so this rise and decrease will be proportional. For every 1 milli equivalent increase in anion gap, there will be equal amount 1 milli equivalent decrease in bicarbonate. This is one relationship you should know in addition. It means if anion gap has increased by 1 milli equivalent, bicarbonate must have decreased by 1 milli equivalent. This is a very, very important relationship that should be kept in your mind. Now, what will be the causes of high anion gap metabolic acidosis? How will acid be added to your body? Multiple phenomena are there. Acids such as keto acids adding to your body is ketoacidosis, lactic acidosis. When will all these acids added to your body not go out? During renal failure. And also toxins. You must be knowing, any alcohol will get converted into aldehyde, later into acid. Ethanol, acetic acid, methanol, formic acid, all these are responsible. Write down causes of high anion gap metabolic acidosis. 4 groups. Toxins, drugs, ketoacidosis. Ketoacidosis such as diabetic ketoacidosis, starvation ketoacidosis, alcoholic ketoacidosis, then lactic acidosis. When will all these acids formed not go out from your body? Renal failure. Toxins or drugs, like I told you, alcohol will ultimately get converted into acid. Paraldehyde, ethylene glycol. The commercial name of ethylene glycol is antifreeze. This ethylene glycol can get converted into oxalic acid in the body. that can result in oxalate crystals in the urine. Can anybody tell me one drug that is acid? It is aspirin. Methanol poisoning, paraldehyde poisoning, ethylene glycol poisoning, aspirin. Then lactic acidosis, it is classified further into two. The usual lactic acidosis type A, unusual type B. Type A lactic acidosis is the usual lactic acidosis. How lactic acidosis happens usually? Because of either reduced perfusion or decreased oxygen to the tissue. Whereas type B lactic acidosis, the perfusion, oxygenation will be normal. Still lactic acidosis happens. What are the causes of usual lactic acidosis type A? We all know, shock. What is the source of oxygen to your tissues? You must be knowing lactic acidosis is formed as a part of anaerobic metabolism when oxygen is less. What brings oxygen to your tissues? Blood. In shock, there is no sufficient perfusion. Anemia. In that blood, what carries oxygen? Hemoglobin. In anemia, hemoglobin is less. Why in carbon monoxide poisoning? In carbon monoxide poisoning, the hemoglobin tightly binds with carbon monoxide and there will be no space for oxygen to bind. Oxygen cannot be bound to hemoglobin and oxygen will not reach the tissues. Coming to type B lactic acidosis, it is further classified into systemic cause. Next will be drugs. What are the systems handling lactic acid in your body? One is your liver. Liver breaks down lactic acid. Whenever there is liver failure, lactic acid is not broken down, it remains in your body. Kidney excretes lactic acid. Whenever there is renal failure, lactic acid is retained. Drugs such as zidovudine, metformin, and isoniazid. These drugs can involve in the lactic acid pathways indirectly and result in its accumulation. Very, very important. Always high anion gap with relevant history is very significant. Anion gap high is generally not an incidental finding. It indicates one of the following. Whenever you see a patient with high anion gap, think in terms of toxin or drug use, ketoacidosis, lactic acidosis, renal failure, lactic acidosis, renal failure, ketoacidosis, toxin or drugs. That's why high anion gap with relevant history should always be considered significant in the emergency department. Next, coming to normal anion gap metabolic acidosis. Again the same compartments: sodium, chloride, bicarbonate. There is a gap called as anion gap. Here the reason for this is not addition of acid. Because of some disease, bicarbonate is lost excessively from your body. For whatever bicarbonate is lost, your kidneys will take back equal amounts of chloride in return. Because bicarbonate is lost, it is metabolic acidosis. Bicarbonate is lost, it is metabolic acidosis. Chloride has come back. So the total volume of compartment will not change, anion gap will not change. Because chloride has come back, this is sometimes also called as hyperchloremic metabolic acidosis. Hyperchloremic metabolic acidosis. What is the common cause of this metabolic acidosis? Normal anion gap. Now one of you should have it out. Sir, even in high anion gap metabolic acidosis, when bicarbonate was getting consumed as a buffer, if chloride reabsorption was happening, anion gap should have stayed normal. What is absent here, present there? Not allowing chloride absorption, this acid anion. This acid anion immediately will accumulate, not allowing chloride reabsorption. But normal anion gap metabolic acidosis is not addition of acid. It is due to loss of bicarbonate. What is the important cause? Everybody must have experienced this disorder in diarrhea. In diarrhea, there is loss of lower GI secretions. Loss of lower GI secretions rich in bicarbonate. Rich in bicarbonate. And where is this bicarbonate coming from? Pancreas. Because bicarbonate is lost, there will be metabolic acidosis. Opposite to diarrhea is vomiting. In vomiting, what is the acid-base disorder? There is loss of upper GI secretions. Loss of upper GI secretions rich in acid. Your upper GI is pulled with acid. There will be metabolic alkalosis. If acid is lost, there will be metabolic alkalosis. Simple words: diarrhea, metabolic acidosis, vomiting, metabolic alkalosis. Vomiting, metabolic alkalosis. Next, what happens in hyperaldosteronism? Hyperaldosteronism. What happens in hypoaldosteronism? Now, where is this aldosterone actually coming to play? In the kidney, this aldosterone is required for sodium and water reabsorption. For whatever sodium is coming inside, what will be lost in the urine? K plus and H plus. When there is hyperaldosteronism, excess sodium, for whatever excess sodium is coming inside, K plus and H plus will be lost. So write down, in hyperaldosteronism, due to increased sodium retention, there will be loss of H plus and K plus from body, because H plus and K plus are lost. Loss of H plus is metabolic alkalosis. H plus is an acid, it is lost, metabolic alkalosis. And K plus is also lost, hypokalemia. Now in hypoaldosteronism, opposite. Aldosterone is not functioning, so sodium will not come inside. If sodium is not coming inside, what will not go out from your body? H plus and K plus. If H plus is staying excessively, metabolic acidosis. K plus is staying excessively, hyperkalemia, due to decreased sodium reabsorption. H plus and K plus retained in body. H plus and K plus retained in body. That results in metabolic acidosis and hyperkalemia In simple words, when there is hyperaldosteronism, there is metabolic alkalosis, hypokalemia. In hypoaldosteronism, we have metabolic acidosis and hyperkalemia. With this background, let us see the important causes of normal anion gap metabolic acidosis. It can be classified into GIT causes and renal causes. These renal causes, majority you would have come across in your nephrology. Just I'll give you the list. GIT cause, the primary mechanism in this GIT cause is there is loss of lower GI secretions. In all this, ultimate event is loss of lower GI secretions rich in bicarbonate. What are the conditions? Diarrhea, you already know, loss of lower GI secretions rich in bicarbonate. Then we have an entity called as enterocutaneous fistula. Entero means intestine, cutaneous means skin, fistula means opening. From the intestine there is an opening to outside. Through this opening, what will be lost? Lower GI secretions rich in bicarbonate. Pancreatic fistula. What is most common source of bicarbonate to your lower GIT? Pancreas. Whenever there is an opening from pancreas to outside, bicarbonate rich secretions are lost. Next is a surgery. This is a separate mechanism. Ureterosigmoidostomy. Now, when do you do this surgery? When there is bladder carcinoma, your ureters cannot drain into bladder. We bring the ureters and connect them to sigmoid colon. What does ureters contain? Urine. What does urine contain? Chloride. Because excess chloride is coming into the intestine, your intestine loves chloride. So there will be chloride reabsorption. For whatever chloride has been taken in, for whatever negative has come in, a negative will be thrown out. What is that negative thrown out? Bicarbonate. Bicarbonate lost in patient's excreta. Always chloride and bicarbonate will have an inverse relationship. Because bicarbonate is lost, there will be metabolic acidosis. equal amount of chloride has been absorbed. There will be normal anion gap, no change in anion gap. Coming to the renal causes. In the renal causes, first category will be the renal tubular acidosis. I am not going to discuss regarding RTA right now because it must have been extensively dealt in your nephrology. Then next we have drugs. Drugs, especially ACE inhibitors, aldosterone antagonist, and next will be carbonic anhydrase inhibitors. First, let us see how will ACE inhibitors and aldosterone antagonists behave. Whenever you give ACE inhibitors, what is going to happen? ACE inhibitors, aldosterone will not be formed. Whenever you give aldosterone antagonist, aldosterone will not work properly. These two conditions will result ultimately in decreased aldosterone activity. So it is similar to hypoaldosteronism. What will be the end result in hypoaldosteronism? Metabolic acidosis, hyperkalemia. What are the side effects of ACE inhibitors? Metabolic acidosis, hyperkalemia. What will be the side effect of aldosterone antagonist? Metabolic acidosis, hyperkalemia, because they ultimately reduces the aldosterone activity and it creates a situation similar to hypoaldosteronism. Where is this enzyme carbonic anhydrase helpful? In the proximal convoluted tubule for reabsorption of bicarbonate. When you inhibit this enzyme, there will be decreased bicarbonate reabsorption in PCT. In PCT, proximal convoluted tubule. This reabsorption in proximal convoluted tubule is responsible for bicarb reserves. Bicarb reserves in your body. Because the reabsorption is not happening, in your body bicarb reserves will decline. These are the causes of normal anion gap metabolic acidosis. GIT causes, renal causes. Next, coming to metabolic alkalosis. This metabolic alkalosis is classified into two forms. Based on two types of classification. First is based on mechanism. Next classification is based on response to saline. There are two classifications. Based on mechanism, based on response to saline. Whether this metabolic alkalosis responds to saline, yes or no. Based on mechanism, there are three categories. Category 1, metabolic alkalosis predominantly due to hypovolemia. Category 2, metabolic alkalosis due to unnecessary aldosterone excess. Category 3, metabolic alkalosis due to some primary genetic defects of renal tubules, such as Bartter syndrome, Gitelman syndrome, Liddle syndrome. Again, these would have been extensively discussed in your nephrology. All this ultimately will result in metabolic alkalosis. Let us see what happens in category 1 and category 2. Those resulting in significant acid and volume loss, vomiting, upper GI secretions, vomiting, Ryle's tube aspiration. Here also you put the tube in the stomach and bring out upper GI secretions. And diuretic use also can cause significant hypovolemia. The end result in all this can be volume loss. Whenever there is less volume in your body, what is the system getting activated? Renin, angiotensin, aldosterone system. When there is excess aldosterone activity, these patients ultimately will land up in metabolic alkalosis. Next, coming to aldosterone excess, unnecessary aldosterone excess. Diseases such as primary hyperaldosteronism, Cushing's syndrome, renin secreting tumor, renin secreting tumor. So all this are responsible. They ultimately result in metabolic alkalosis. You know the mechanism behind primary hyperaldosteronism. Excess aldosterone means metabolic alkalosis. Cushing's syndrome is not mineralocorticoid excess. It is glucocorticoid excess. These glucocorticoids will have some amount of mineralocorticoid resulting in metabolic alkalosis. Renin secreting tumor, if renin increases, aldosterone also increases. Ultimately, there will be metabolic alkalosis. And differentiating feature here is this will be associated with hypertension. Normally, when should aldosterone activity happen in your body? When there is hypovolemia. So this aldosterone activity will bring the volume to normal. Once the volume becomes normal, by negative feedback, aldosterone activity will stop. But here, there is no volume loss at all. There is continuous aldosterone activity. If there is continuous aldosterone activity, 24/7, your body will be taking sodium and water. That will result in extracellular fluid volume expansion and hypertension. Whereas in category 1, this aldosterone activity is due to volume loss. Once the volume loss is corrected, aldosterone activity automatically gets inhibited. So there will be no excess water reabsorption beyond what is required for the body. So the blood pressure will be near normal. But here there is excess sodium and water reabsorption resulting in hypertension. Another differentiating feature here is, in this situation, urinary chloride can be less than 20 milliequivalents. Whereas here urinary chloride tends to be more than 20 milliequivalents. What is the logic behind this? Category 1 is predominantly due to hypovolemia. Tell me students, when there is less volume in your body, what will your kidneys try to do? It will try to retain water. How is water retained? By salt. There will be salt and water retention. What does salt contain? Chloride. Because chloride is kept into the body. Within the urine, chloride will be less. Whereas in category 2, it is associated with hypertension, volume overload. Is there any need for your kidneys to retain excess salt and water? No. Kidneys will not be interested in retaining salt. So within the urine, chloride can be lost usually. Urinary chloride will be more than 20 milliequivalents. But when it comes to the clinical practice, the next classification is very important. Based on response to saline, it is classified into saline responsive metabolic alkalosis, where the metabolic alkalosis immediately can be corrected by saline. Other is saline unresponsive. Can anybody tell me out of these three categories, which is saline responsive? Yes, it should be category 1, because category 1 is happening due to volume loss. Now if you correct the volume, the trigger to renin, angiotensin, aldosterone system will be lost. The metabolic alkalosis will also resolve. Whereas saline unresponsive will be category 2 and category 3. What is the reason? Category 2 is already associated with volume overload. Now if you give excess saline, this patient can develop cardiac overload and heart failure. Whereas category 3, these are due to some primary renal genetic defects. Even if you give saline here, the genetic defects will not be altered. Metabolic alkalosis will persist. So in category 2, there is no point in giving saline because of hypertension. In category 3, even if you give saline also, it is not going to completely change those genetic defects. There will be persistence of metabolic alkalosis. So in clinical practice, why this classification is very important? If it is a saline responsive case, give saline, there ends the matter. If it is saline unresponsive case, you have to evaluate further, find the reason and treat the underlying disorder. Now if you do a clinical scenario, you will understand this. This patient with vomiting brought to emergency department, on examination BP low, at present no active vomiting, ABG showing severe metabolic alkalosis. How to treat metabolic alkalosis? In this situation, what is the initiating event for metabolic alkalosis? Vomiting. Now the vomiting has subsided, but still metabolic alkalosis is persisting. What might be the persisting event for metabolic alkalosis? I say it is due to volume loss. That must have triggered renin, angiotensin, aldosterone system. That must have triggered the development of metabolic alkalosis. How could I say there is volume loss? BP is still persistently low. The question asked here is how to treat metabolic alkalosis. I say the answer is IV normal saline. Why is it so? Why metabolic alkalosis is persisting? Volume loss. Now if you give saline, you are going to correct the volume loss. So the trigger for renin, angiotensin, aldosterone system is lost. Metabolic alkalosis is gradually corrected. This is a clear-cut case of saline responsive metabolic alkalosis because it is responding with saline. Next acid-base disorder is respiratory acidosis. I have discussed in detail regarding respiratory acidosis in type 2 respiratory failure. What is type 2 respiratory failure? It is hypercapnia. Hypercapnia means increased CO2. Increased CO2 is nothing but respiratory acidosis. Write down. Respiratory acidosis is nothing but type 2 respiratory failure. Coming to respiratory alkalosis. In description of respiratory alkalosis, Harrison mentions that chronic respiratory alkalosis is most common acid-base abnormality in critically ill patient. Let us see the causes. You will understand the reason. First group of causes: pain. People will hyperventilate. Panic. They will hyperventilate. Few young females have psychogenic hyperventilation. They just keep on hyperventilating for no reason. Excess progesterone in the body. Progesterone can directly stimulate respiratory center. These four are the first group of causes. Coming to the second group, toxins produced in the body either due to sepsis or cirrhosis. These toxins are also capable of stimulating respiration. They can stimulate respiration. Then diseases responsible for hypoxemia. Any disease that has resulted in hypoxemia will stimulate respiratory receptors. As long as your respiratory effort is intact, there will be hyperventilation. And once they hyperventilate, what is the gas going out in excess? CO2. Next important group, accidental mechanical hyperventilation. Whenever you connect a patient to a mechanical ventilator, you are going to set some respiratory rate. Generally we keep it physiological, 12 to 15 per minute. Now a new resident has come to the ICU and he has accidentally increased it to 20. For him 20 is high, that can result in CO2 washout, accidental mechanical hyperventilation. Now why chronic respiratory alkalosis is most common acid-base abnormality in critically ill patient? A critically ill patient might be in pain, might be in panic, might be in sepsis, might be having hypoxemia, might be connected to a mechanical ventilator. Because all this happens in critically ill patient, they thought it is the most common cause in them. The next important reason will be drugs. Drugs such as aspirin and also theophylline, aminophylline. These have tendency to stimulate respiratory center. By this, we have completed simple acid-base disorder, individual acid-base disorders. Metabolic acidosis, metabolic alkalosis. Respiratory acidosis, respiratory alkalosis. Next we have mixed acid base disorder. Point to know here, for evaluation of mixed acid base disorder, clinical history very important. Without clinical history, very difficult to interpret. Clinical history, very important. For your convenience, I am rewriting the algorithm once again. After pH, we try to identify the primary disorder. This primary disorder can either be primary respiratory disorder or metabolic disorder. If it is a primary respiratory disorder, what compensation we calculate? Metabolic. Here it will be respiratory. In majority, given bicarbonate correlating with expected bicarbonate. On this side, given CO2 correlating with expected CO2. If given and expected are correlating, it is a simple acid base disorder. But rarely there can be a relation like this. Given bicarbonate is not correlating with expected bicarbonate. On this side also, given CO2 not correlating with expected CO2. What is this called as? A mixed acid base disorder. See here, students, I'll explain. If given and expected are correlating, it is simple acid base disorder. If they are not correlating, it is mixed. So there can be two mathematical possibilities. A given more than expected or given less than expected. So write down possibility 1, mathematical possibility. Given bicarbonate very much higher than expected bicarbonate. Possibility 2. Given bicarbonate very much less than expected bicarbonate. Here also possibility 1. Given CO2 very much higher than expected CO2. Possibility 2. Given CO2 very much less than expected CO2. First we will see mixed acid base disorder with primary respiratory disorder. Say for example, there is a patient with COPD. As a part of COPD, his CO2 has increased from normal value of 40 to 60. To call it as a compensatory phenomena, bicarbonate should increase from 26 to how much? Because it is a chronic disorder, for 10 it is 4. For 20 it is 8. 26 plus 8, 34. So if it reaches to 34, it is adequate compensation. But in the question, it is 38. What does it mean? Body's compensatory phenomena can only bring it to 34. But it is 38. So this is a situation where given bicarbonate is more than expected bicarbonate. There is some extra bicarbonate in the body. Anywhere extra bicarbonate is additional metabolic alkalosis. See whether this patient has developed some vomiting. This is a situation. Given bicarbonate more than expected. There is extra bicarbonate. Anywhere extra bicarbonate is additional. Metabolic alkalosis. Example, COPD with vomiting. Another patient with COPD. His CO2 has increased from 40 to 60. To call it as a compensatory phenomena, bicarbonate should increase to how much? 34. But it has decreased to 30. Body's compensatory phenomena should bring it to 34. But it has remained at 30. There is some abnormal decrease in bicarbonate. This is a situation where given bicarbonate is very much less than expected. Anywhere abnormal decrease in bicarbonate is called as additional metabolic acidosis. See whether the patient has developed some diarrhea. Given bicarbonate is less. Abnormal decrease in bicarbonate. So this is coexisting additional metabolic acidosis is a possibility. Example, COPD with diarrhea. Very simple words. If CO2 increases to this level, bicarbonate should come to this level. If it is increasing beyond this, there is some extra bicarb in the body. Anywhere extra bicarb is additional metabolic alkalosis. If it has decreased abnormally, anywhere abnormal decrease in bicarbonate is called as additional metabolic acidosis. Nothing but a mixed acid base disorder. Two independent disorders are coexisting. Next, coming to mixed acid base disorder with respect to primary metabolic disorder. Say for example, this fellow is having DKA. As a part of DKA, CO2 bicarbonate has decreased to 10. What will be the compensation of CO2? We have the formula. Expected CO2 1.5 into bicarbonate plus 8 plus or minus 2. CO2 should come down to 21 to 25. But now it has increased it to 35. Body's compensatory phenomena can only bring it to 25. But there is an increase. So it means there is some extra CO2 in the body. Anywhere extra CO2 is called as additional respiratory acidosis. This is a situation where given CO2 is very much higher. It means there is extra CO2. So this is additional respiratory acidosis. Additional respiratory acidosis in DKA is very important, because in DKA there can be diabetic ketoacidotic coma that can result in respiratory depression and increased CO2, ultimately causing respiratory arrest and death. Example, DKA and patient is having some altered sensorium. It might be due to diabetic ketoacidotic coma. Next patient, also with DKA, his bicarbonate has decreased to 10. As a compensatory phenomena, CO2 should come down to 21 to 25. But now it is only 15. What does it mean? Body's compensatory phenomena should bring it to 25. But it has decreased beyond this. There is some extra CO2 washout. Anywhere extra CO2 washout should be considered as additional respiratory alkalosis. See whether this fellow is hyperventilating because of panic. This is a condition where given CO2 is very much less than expected CO2. Anywhere extra washout of CO2 is additional respiratory alkalosis. Example, DKA and anxious patient. In simple words, if bicarbonate decreases to this level, CO2 should also come to this level. If it has increased significantly, anywhere extra CO2 is additional respiratory acidosis. If it has decreased, anywhere extra washout of CO2 is additional respiratory alkalosis. Nothing but mixed acid-base disorder. If you do some questions, you will understand this better. Few practice questions. Patient with DKA, pH, CO2, bicarbonate is given. Follow the 5-step algorithm, you will get the answer very easily. Draw arrow marks. Decrease, decrease, decrease. Step 1. See the pH. It has decreased. Anywhere decrease in pH is acidosis. Step 2. What is the primary? Change in pH with respect to parameters, same direction. What should be the name? Metabolic. Step 3. Calculate compensation. Metabolic acidosis, respiratory compensation. The formula 1.5 into bicarbonate plus 8 plus or minus 2. Bicarbonate is 10 here. 15 plus 8 plus or minus 2. 23 plus or minus 2. 21 to 25. Given is how much? 22. Expected is also correlating. This is a situation where given bicarbonate in the question is correlating with given CO2 in the question is correlating with expected CO2 calculated. So this is metabolic acidosis with compensatory respiratory alkalosis, a simple acid-base disorder. Next, coming to another patient, DKA anxious, decreased, decreased, decreased. No doubt it is metabolic acidosis. In a primary metabolic acidosis, when bicarbonate decreases to 10, CO2 should come down to 21 to 25, but it has decreased to 16. This is a situation where given CO2 in the question is very much less than expected CO2. It means there is extra CO2 washed out from the body. Anywhere extra CO2 washed out is called as additional respiratory alkalosis. What might be the reason? This patient is anxious. He must be hyperventilating in panic. Next we have patient with DKA and altered sensorium. Decrease, decrease, decrease. Anywhere decrease in pH is acidosis. It is metabolic because everything is in same direction. In a primary metabolic disorder, when bicarbonate decreases to 10, CO2 should come down to 21 to 25, but it has increased. This is a situation where given CO2 is very much higher than expected CO2. Given CO2 is very much higher than expected CO2. So this is a condition where there is extra CO2 in the body. Anywhere extra CO2 is additional respiratory acidosis. What might be the reason? Patient is in altered sensorium. Because of diabetic ketoacidotic coma, there might be some respiratory depression resulting. This is how we have to interpret mixed acid-base disorders. Let us see some practice questions and few concepts before we conclude. There is a 20-year-old anxious female with chronic hyperventilation. ABG results are given. What is the abnormality? Whenever they give you any ABG, first think history wise what might be the possibility. Chronic hyperventilation. There can be possibility of chronic respiratory alkalosis. Once try to correlate this ABG wise. ABG wise, what are the parameters? pH 7.48, PaCO2 25, bicarbonate 20. Quickly draw arrow marks. pH increased, PaCO2 decreased, bicarbonate decreased. Anywhere increased pH is alkalosis. Change in pH with respect to parameters opposite. So what should be the primary? Respiratory. Very simple. Answer is respiratory alkalosis. Then another patient, anxious female, chronic hyperventilation. There is carpopedal spasm. Abnormality. So it is the same question. But she has developed carpopedal spasm. It is a respiratory alkalosis. Now why in respiratory alkalosis there can be carpopedal spasm suggestive of hypocalcemia? For this you should have some basic knowledge of calcium handling in your body. So in your body calcium exists in two forms. One is ionized form, which is majority, and other is bound form, that is to albumin. Ionized form and albumin bound. So it will be in a normal individual like this. Some amount of calcium is always bound with albumin. You must be knowing albumin is one of the negative charged substance in your body. It not only gives space to calcium, it also gives space to H plus ions. So in a normal individual, apart from free calcium, some calcium is albumin bound. Along with calcium, what else is albumin bound? H plus is albumin bound. Suppose a patient is developing acidosis or alkalosis. Let us see how does it alter. Say for example, he developed acidosis. Now whenever there is acidosis in your body, there will be lot of H plus within the blood. Free H plus is very dangerous to your body. If there is excess free H plus, it is going to reduce the pH so that your body cannot do metabolism properly. Now what will your body do to fight against this H plus? One of the mechanism is your body will start releasing calcium from the albumin. Now you can see here in a normal individual 3 H plus were there and 2 calcium were there. Now what will your body do is this albumin, it will start binding excess H plus, releasing calcium. So previously 2 calcium were albumin bound. Now only 1 calcium is albumin bound. So this calcium has been released into circulation. So because of that, what will happen? There can be excess calcium in circulation causing hypercalcemia like situation. Acidosis can release calcium release from albumin. Now what happens in alkalosis? Opposite. In alkalosis, the H plus in your body decreases because in your blood there is less H plus. If again there is alkalosis also, metabolism will not happen. Now what will this albumin do? It will start releasing H plus into circulation to fight against this condition. Because H plus is getting released into circulation, now sites on the albumin will be free and gradually calcium will come and bind with albumin. So calcium from the circulation will start binding with albumin. Because excess calcium from the circulation is binding with albumin, within the circulation, calcium can decrease, resulting in hypocalcemia like situation. So what happens in alkalosis? Alkalosis can enhance calcium binding to albumin, and this was noticed more with respiratory alkalosis when compared with metabolic alkalosis. Even metabolic alkalosis can cause hypocalcemia, carpopedal spasms, but studies have shown that it was more with respiratory alkalosis. So here treatment is very simple. So no need to give any calcium infusion because it is a transient phenomena. Just ask the patient to relax, stop hyperventilating. If required, you can do rebreathing. So rebreathing in the sense, just give a paper bag, ask the patient to inhale and exhale in the same bag. So once she starts exhaling into that same bag, she is exhaling carbon dioxide and she is again inhaling that carbon dioxide. So the respiratory alkalosis will be corrected because carbon dioxide is coming more into your body. Respiratory alkalosis can be corrected and this can be easily reversed. So what you need to know here is alkalosis can promote calcium to bind. Alkalosis can promote calcium to bind. So calcium will be less in circulation. That can result in hypocalcemia like situation. So next question, practice question, amyotrophic lateral sclerosis, lot of history, ABG is given. So history wise, amyotrophic lateral sclerosis, chronic neuromuscular disorder. ABG wise, so very simple, pH 7.34, PaCO2 60, bicarbonate 34. Just draw arrow marks, decrease, increase, increase. Anywhere decrease in pH, acidosis. Change in pH with respect to parameters, opposite. What should be the primary? Respiratory. Acute or chronic? Chronic. Next step, pH, primary process, compensation. 40 to 60, 20. It has increased by 20. So in chronic respiratory acidosis, for 10 it is 4. For 20 it is 8. 26 plus 8, 34. Given and expected correlated. Chronic respiratory acidosis with compensatory metabolic alkalosis. So the best answer is compensated respiratory acidosis. A 6-year-old child, metabolic acidosis, so many parameters are given, you want to know anion gap. Let them give whatever they want. Anion gap calculation, you should only use these parameters, sodium minus chloride plus bicarbonate. How much is sodium? 140. How much is chloride? 112 plus 16. 140 minus 128, it is 12. It is normal anion gap. Normal anion gap. Now coming to a complicated situation called as mixed metabolic disorder. See, mixed respiratory disorder cannot be existing. Respiratory acidosis and respiratory alkalosis together they cannot exist because it happens to the same respiratory tract. But there can be metabolic acidosis and metabolic alkalosis coexisting. Suppose patient is having renal failure. Renal failure will cause metabolic acidosis. Patient now developed vomiting. Patient can also have metabolic alkalosis. So for mixed metabolic disorder, very important is actually the concept of anion gap and also delta anion gap. See, especially you should know in mixed metabolic disorder comparison of delta anion gap and delta bicarbonate. So generally the acidosis will be high anion gap metabolic acidosis. High anion gap metabolic acidosis will be present. Now how to go around this delta anion gap and delta HCO3? As I told you, when there is high anion gap metabolic acidosis, for every 1 milliequivalent increase in anion gap, bicarbonate decreases by same amount. So change in anion gap and change in bicarbonate will be similar. So if it is a pure high anion gap metabolic acidosis, the rise in anion gap, that is delta anion gap, will be similar to fall in bicarbonate, a decline in bicarbonate. Now suppose anion gap has increased from 10 to 20. Bicarbonate should decrease from 25 to 15. So 10 to 20, the change is 10. 25 to 15 also, change is the same. So the change will be the same. How much anion gap has increased? If anion gap has increased by 10, bicarbonate also will decrease by 10 if it is a single high anion gap metabolic acidosis. Let us see few situations. Scenario 1. Delta anion gap more than delta bicarbonate. So anion gap has increased this much. So how much bicarbonate should decrease? Bicarbonate also should decrease by this much. But here delta anion gap is more than delta bicarbonate. So bicarbonate, instead of decreasing this much, it has only decreased some. So it means that bicarbonate is not declining as expected. So something is adding bicarbonate to the body. So this is a situation of accumulation of extra bicarbonate due to an additional metabolic alkalosis. So example for this will be renal failure, which causes high anion gap metabolic acidosis with vomiting. So if you do some questions, you will understand this better. Scenario 1. In a normal, if it is a pure high anion gap metabolic acidosis, if anion gap increases by this much, bicarbonate should also fall simultaneously. Bicarbonate is not falling. So something is not allowing bicarbonate to decrease. Some disorder has added bicarbonate to the body. Something which adds bicarbonate is additional metabolic alkalosis. Example, renal failure and vomiting. Scenario 2. Delta anion gap less than delta bicarbonate. It means that if anion gap increases by this much, bicarbonate should decrease by this much. Now anion gap only increased by this much, but bicarbonate has significantly decreased. It means there is excess decline in bicarbonate happening. So what does it signify? There is loss of extra bicarbonate due to an additional metabolic acidosis. So here there are two metabolic acidoses. Patient might have high anion gap metabolic acidosis, DKA. Along with that, he might also have a normal anion gap metabolic acidosis. Because there are two acidoses, bicarbonate loss is more significant. Now if you do these few questions, you will understand. So scenario 1, where bicarbonate decline is not happening. Scenario 2, where there is excess decline in bicarbonate happening. So don't worry about this theory. If you do it in practice, you will understand better. So question number 1. There is a patient with renal failure and vomiting in ICU. In ICU, any type of acid-base disorder can happen. Let us see ABG-wise approach. Renal failure. It causes high anion gap metabolic acidosis. And there is vomiting. Vomiting will cause metabolic alkalosis. Now this is a peculiar situation. Two mutually opposite disorders. One is metabolic acidosis, other is metabolic alkalosis. When there are two mutually opposite disorders, what you can expect? You can expect the pH to be normalized. sorry, this is history wise approach. According to history, patient is having high anion gap metabolic acidosis with metabolic alkalosis. Now let us see ABG wise approach. ABG wise. So by history, what you can suspect, there are two disorders and pH might be normalized. pH 7.40, PaCO2 40, bicarbonate 25. If you don't have the history, if you just see these parameters, you will be forced to write it as normal parameters. But there is significant history and anion gap has increased. Normal anion gap is 10, it has increased to 20. As I told you previously, anion gap is not incidental. It generally indicates some pathology. High anion gap with relevant history. There is a relevant history called as renal failure. You should always take it as significant. So when there is high anion gap with relevant history, you should always entertain possibility of high anion gap metabolic acidosis. So this is having a high anion gap metabolic acidosis. You should correlate with history. There is renal failure. There is high anion gap metabolic acidosis. Now let us see the delta concept, delta anion gap and delta bicarbonate. You know this relation for every, when there is high anion gap, 1 milli equivalent increase in anion gap, bicarbonate should decrease simultaneously by same amount. Now in this question, if you notice, anion gap, if you take normal value as 10, it has increased to 20. It means it has increased by 10. So delta anion gap, change in anion gap is 10. So in the same way, what should happen to bicarbonate? If you take normal bicarbonate as 25, if anion gap has increased by 10, bicarbonate should also decrease by 10. So it should have reached to 15. But how much is the bicarbonate here? 25. If it was a single high anion gap metabolic acidosis, anion gap, if it has increased by 10, bicarbonate should have stayed at 15 only. But here bicarbonate has increased to 25. It means there is some other disorder adding extra bicarbonate. From 15, some other disorder has added extra bicarbonate and brought it to 25. It is a situation where given bicarbonate in the question 25 is very much higher than expected bicarbonate. So something has brought bicarbonate from 15 to 25. There is extra bicarbonate added to your body. Anywhere extra bicarbonate is additional metabolic alkalosis. See the history. Is there any possibility of metabolic alkalosis? Yes, vomiting. So in this scenario, if you calculate delta bicarbonate, so it has to delta bicarbonate. Normal bicarbonate 25 given in this question is also 25. Bicarbonate did not decrease at all. So delta bicarbonate is 0. It did not decrease at all. So this is a situation where delta anion gap is more than delta bicarbonate. So bicarbonate decline did not happen. So this is a situation of additional metabolic alkalosis. Like that you can apply the concept, or you can just logically think like this also. Anyway, the concept is the same. If it is a pure high anion gap metabolic acidosis, the change in anion gap and change in bicarbonate should correlate. If it is not correlating, there is some additional metabolic disorder, because here anion gap has increased, bicarbonate has not decreased. So something is adding bicarbonate and not allowing it to decrease. So anything that will add bicarbonate is additional metabolic alkalosis. So this is a situation of high anion gap metabolic acidosis with additional metabolic alkalosis. Now another patient, DKA, develops diarrhea in ICU, performed ABG, this was the parameters. Now history wise, DKA will cause high anion gap metabolic acidosis. Diarrhea will cause normal anion gap metabolic acidosis. So there are two metabolic acidosis. Let us see the relevance in ABG. pH 7.10, PaCO2 15, bicarbonate 5. Bicarbonate has extremely decreased, anion gap 20. Decreased. So this anion gap has increased. So no doubt it is an high anion gap metabolic acidosis. So whenever there is high anion gap metabolic acidosis, according to ABG algorithm, automatically you should compare change in anion gap and change in bicarbonate. Now in this patient, anion gap has increased from normal value of 10 to 20. It has increased by 10. Okay. So what should happen to bicarbonate? So if you take bicarbonate value normal as 25, it should decrease by same amount and it should reach to 15. But in the question it is 5. So this is a situation where given bicarbonate in the question 5 is very much less than expected bicarbonate. So if it was a single high anion gap metabolic acidosis, bicarbonate should have stayed at 15, but it has further decreased to 5. It means there is some other disorder causing bicarbonate to decrease excessively than what is required. Any disorder that causes bicarbonate to decrease excessively should be called as metabolic acidosis. So there is another additional metabolic acidosis. So there is one high anion gap metabolic acidosis with a normal anion gap metabolic acidosis. You can also see with respect to delta anion gap and delta bicarbonate. How much is delta anion gap in this patient? Anion gap has changed by 10. So delta anion gap is 10. How much is delta bicarbonate? How much did the bicarbonate change? From normal value of 25, it has changed to 5. So 25 minus 5, it is 20. So it means when compared to anion gap, there is excess fall in bicarbonate. So this is a situation where delta anion gap is less than delta bicarbonate. So there is excess fall in bicarbonate. So whenever anion gap increases by this much, bicarbonate should also decrease by this much, but it has decreased excessively. Anywhere excess fall in bicarbonate should be called as additional metabolic acidosis. So there are also other delta ratio. There is also something called as delta anion gap, delta bicarbonate ratio also, but these are not required for you as this is all difficult. For practical purpose, you can just use this formula. You can just compare change in anion gap and change in bicarbonate, which is given in Harrison also. So this is a situation of high anion gap metabolic acidosis with additional metabolic acidosis. So the answer is option D. Let us conclude with one last question. 84-year-old female, diarrhea, the vitals and ABG is given. So once again, history wise, what will diarrhea cause? A simple metabolic acidosis. So when I just write metabolic acidosis, it means mostly it is normal anion gap. Okay. ABG wise, pH 7.29, PaCO2 24, bicarbonate 10. Quickly draw arrow marks and the 5-step approach, students. Step number 1, what is pH? pH is decreased, so it is acidosis. Step number 2, what is primary? Change in pH with respect to parameter, same direction. What should be the name? Metabolic. Step 3, compensation. It is metabolic disorder, respiratory compensation. 1.5 into 10 plus 8 plus or minus 2. If you calculate, it will be 21 to 25 mmHg. Given is how much? 24. Expected correlating. Metabolic acidosis with compensatory respiratory alkalosis. Step number 4. Calculate anion gap. Anion gap, sodium 137 minus chloride 117 plus bicarb 10. 137 minus 127, 10. Put it together. It is normal anion gap metabolic acidosis with compensatory respiratory alkalosis. This is your final impression. So the answer, non-anion gap, means it is not high anion gap, it is normal anion gap metabolic acidosis and compensatory respiratory alkalosis. This is how you should approach ABG. First go through the clinical history, then pH, what is primary, compensation, anion gap. If there is high anion gap, you should compare change in anion gap to change in bicarbonate. Either you can use the delta relation or you can just compare the change in anion gap to change in bicarbonate. And final step is to give your last impressions. What will be your final impression? So as I told in the beginning, this is the first part video which constitutes all the practical aspects. So these are the practical aspects that you should be thorough while facing a patient. But while writing your exam, they will ask you more of theory aspects. They'll just give you respiratory acidosis. They'll ask you to not only write about it, but also the compensatory phenomena. They'll ask you the buffering mechanisms. So renal mechanisms of acid-base balance, respiratory mechanisms of acid-base balance. All this I have discussed in this theoretical lecture. So it also contains how to see validity of ABG, these difficult terms such as what is base excess, what is standard base excess, what is standard bicarbonate, what is actual bicarbonate, what is base deficit. Though we don't use it routinely for our clinical practice, just to know these terms I have also given here. Thank you students. Any doubts you can ask me at any time. Thank you. Good night.